Hello? 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 Are you guys able to hear me? Hello?
We can hear you.
Okay, great. So today we are going to be having a bootcamp session on our renal. Okay, so did you guys enjoyed your sessions with Dr. Hasnain? Your world sessions?
Yes, very much.
Okay, that's great. Actually, Dr. Hasnain is our tutor for your world step 2. Those who haven't followed us on Instagram, please do follow us because you are going to be having updates, about our team. Whoever is being introduced into our team, you guys would be having a better idea. So regarding Dr. Hassan, let me mention that he's a trainee at Mayo Clinic now, and he's going to apply for the match next year. He's a really great tutor for step 2, right? So one thing which I want to mention, those of you guys who want who have any friends who are preparing for their step 2, so they can also let them know, because soon we are going to conduct a session for step 2. It's going to be a big help for your friends or anyone, right? Like Dr. Hasnan. And I'll be also looking forward that Dr. Hasnan should take the sessions here in step 1, right? Okay. So let's start our today's. Okay. So first of all, let me just share my screen. Can you guys just see my screen? Hello?
Yes, we can.
Okay. So today we are going to be having a revision kind of session, right? So I need everyone to keep open their first chat in front of them, right? I'll be asking you some questions. We are going to clarify the concepts wherever you feel deficit. So please keep open your first chat in front of you, and you'll be starting from embryology, right? So I'm giving you 2 minutes to take your first chat, open page 596, so that we can start, okay? Hello? Okay, so let's start our today's session, okay? So we'll be starting from kidney embryology, right? All of us know that once your kidney is formed, first of all, we are going to be having a structure that is known as pronephros, right? At 4th week of development, okay? Hello?
Hello, yes.
Okay, so, okay. So as you guys can see that, first of all, we are going to be having a structure which is known as pronephros, right? So pronephros, the kidney basically start developing at the 4th week of your gestation. So what happens that the first structure which is formed is known as your pronephros. Right after that, your pronephros is going to be degenerated, and then we are going to be having the formation of second structure. Can you guys just please fix your mic, Dr. Felix? Okay, thank you. Then we are going to be having formation of a next structure which is known as mesonephros, right? Okay, so the first structure, pronephros, is going to degenerate, and then it's going to be followed by the formation of a next structure, which is known as our mesonephros at the end of 4th week of development, right? So it's going to act as a kidney for the first trimester, for the first 3 months of baby development. It's going to be your interim kidney, right? But after that, you should just keep in mind, it would persist in male or female. What do you guys think? In male, right? In male? It would
Male,
persist.
yes, male.
Yes, in
Yes,
male.
And it would
male,
lead to
yes.
formation of Wolffian ducts. It would lead to formation of Wolffian ducts. So can you guys just tell me what thing or what hormone just lead to persistence of your Wolffian ducts?
Anti-malarian?
Anti-malarian
Hormone.
is going to be, yes, what do you guys think? Persistence of Wolffian duct is supported by which hormone?
Testosterone.
Testosterone keeps it potent, and anti-malarian hormone leads to the formation of it.
Yes. So testosterone is going to lead to the persistence of your Wolffian ducts, and it's then going to, give structures like, the mnemonic for that is seed, right? So your epididymis, your seminal vesicles, and all of those stuff, right? We'll be discussing that in our reproduction module. After that, we are going to be having formation of a third structure, which is known as metanephros, and this metanephros is going to lead to development of your mature kidney, right? So the first structure which come out of your metanephros is going to be your bud, which is going to interact with the blastema, as we already discussed, and we are going to be having formation of your mature kidney. But one thing which you should just keep in mind, what thing give rise to your duct, and what things within the mature kidney give rise to your what things come from the blastema, right? So from the blastema, you are going to be having the functional structures of your kidney. For example, your glomerula, your Bowman capsule, along with that proximal convoluted tubule, the loop of Henle, distal convoluted tubule. But all of the collecting systems basically comes from your blood, right? Including the calyces, your ureter, all of them are your collecting systems of your kidney, right? So this is going to be asked from you guys in your UWorld, so you should just keep this thing in mind, that like the bird is going to give rise to which structure in your mature kidney, while the blastema is going to give rise. Okay, so we have a tumor of blastema. What's the name of that tumor in children? We discussed this yesterday.
Nephroblastoma, Wilms tumor.
Yes, that's basically Wilms tumor seen in children. This it's also very important, like which is due to WT1 mutation, having a lot of cyst. We are going to discuss that in our pathology section, right? The next thing is going to be our Porter sequence. So as we discussed Porter sequence in detail, if you guys know that amniotic fluid is basically your fetal urine. Amniotic fluid is going to provide the cushioning effect to the baby, as well as it's going to be aspirated by your baby lungs in order to have proper stretch towards the lungs and proper development of the lungs, right? So whenever we have less amniotic fluid, either it can be due to failure of your kidneys, agenesis, it can be problems or other problems, for example, for autosomal recessive polycystic kidney disease. All of these things is going to lead to a sequence which is known as Porter sequence. And the main hallmark for Porter sequence is oligohydramnios. If you have less urine, if you have less amniotic fluid, so the cushioning effect on the baby is going to be lost, and the surrounding structures are going to compress the baby, which is going to restrict the growth of baby. And it would appear as twisted faces, twisted skin, extremity problems, and the main thing which is triggering it is any kind of renal failure, lungs hypoplasia, as well as we discussed. Okay, so this was general concept regarding your Porter sequence, which you have to keep in mind. So anything which lead to problems within the kidney, it's going to lead to less production of urine, oligohydramnios, less amniotic fluid, loss of cushioning effect, and loss of development of your lungs hypoplasia. Is that clear? Hello?
Yes.
Yeah.
Okay.
Yes.
So the next thing which we are going to discuss is horseshoe-shaped kidney, really important. So first of all, you should know that horseshoe-shaped kidney is like commonly seen in certain syndromes, right? Like for example, in trisomies, trisomy 18, trisomy 13, and Turner syndromes, like, So can you guys just tell me that what are going to be the features? What's the main genetics involved in trisomy? What do you mean by trisomies? Any idea? Okay, whenever we have like meiotic non-disjunctions of chromosomes, so what would happen as a result of that? You're going to have an extra one copy of the chromosome that is known as trisomy, right? So the cell which is going to be formed is going to have three chromosomes, trisomy, right? So there can be three trisomies, like your 21, 18, and 13. So 13 is which syndrome? Can you guys just tell me trisomy 13? What's the name of that syndrome?
Patau.
Perfect. What about trisomy 18?
Edward
That's an Edward syndrome. What about 21?
Down.
Down
It's a
syndrome.
Down syndrome. So in each and every trisomy, the horseshoe-shaped kidney is going to be one of the feature which you guys are going to see. So in Turner syndrome, you're going to have a lot of MCQ that are going to be associated with horseshoe-shaped kidney, right? So what happens in Turner syndrome, again, it's meiotic. It's basically, okay, it's a problem seen within the woman or man? What do you guys think? Turner
Female.
syndrome.
Female.
Right?
Woman.
Female. Perfect. So what's the main hallmark you should just think of? Okay, what would be the chromosomal, there is going to be 46X chromosome, 46XY chromosome, or
45XO.
Okay, 45
45X.
right?
Loss of one paternal chromosome. Yeah.
Yes, so loss of one paternal chromosome. So what would happen as a result of that? There are a lot of features associated with Turner syndrome, right? And once that's mentioned, you can just clearly identify or diagnose the disease. For example, there is going to be, webbed necks, right? Neck is going to be in a form of web. What else we are going to see?
Short
Cystic
stature,
hygroma.
horseshoe kidney, and cystic hygroma, the web neck, and genital heart abnormalities.
Aortic coarctation.
Okay.
Aortic coarctation, yeah.
Perfect. Aortic coarctation, aortic dissection. So the main feature which you should just remember that the ovaries aren't developed well. If the ovaries aren't developed well,
Yeah.
it means the estrogen is not formed well, right? Because
Yes,
ovaries
and
do
absence of
estrogen
secondary
form, right?
section characteristics.
And secondary
Yeah.
sex purpose, right? So okay, so another kind of question which they love to ask you, that if we have a woman with Turner syndrome and she want to have a baby, so which method is going to be adopted in order to because the women already have a uterus, right? You can give a hormonal replacement therapy in order to grow the endometrial part of the uterus. Along with that, you can also, do a procedure which is known as IV.
IVF.
IVF.
In vitro
IVF.
fertilization, yes. This is the
Yes, in vitro fertilization, right? So basically what happens that there's a horseshoe-shaped kidney is going to be seen. So what kind of MCQs are you going to see on horseshoe-shaped kidney? It's basically fusion of your blastema, right? Or metanephros. Whenever the metanephros fuse at the end, and as it descends upward, it will just give you a structure similar like horseshoe shape. Okay, so you should just simply think of it's basically formed within the pelvis, and as it ascends upward, the ascent is going to be restricted by certain, vessel. What's the name of that?
inferior mesenteric artery.
Inferior mesenteric artery, perfect. And what would be the complaint which this individual will be having? Most of the time, he is going to be asymptomatic with a history of recurrent UTIs. That's all you have to keep in mind. Okay, asymptomatic with recurrent UTIs. Why? Because the entire anatomy of your kidney is disrupted, and as a result of that, what would happen? You're going to have stasis. And stasis is going to be
Hydronephrosis, yeah.
okay, hydronephrosis and recurrent infection. Perfect. So the next thing which we are going to discuss is unilateral renal agenesis. What is unilateral renal agenesis? If the one side of your kidney isn't formed and the other kidney is formed well. So what would we see on the other kidney? Other kidneys have to bear a lot of stress. There's going to be a lot of hyperfiltration. It is also one of the MCQs they're going to ask. Okay, hyperfiltration is going to be seen, and the idea is really simple because your single kidney is now going to undergo the function of both of your kidneys, right? So it's going to be overburdened, simple, right? The next thing is multicystic dysplastic kidney. As we discussed, that this bird is going to differentiate your blastema into mature kidney by sending some signals. So if you have problems with these signaling molecules, there's going to be a condition which is known as multicystic dysplastic kidney, right? Okay, multicystic dysplastic kidney. So this is one thing which you should just keep in mind. Okay, so the next one is duplex collecting system. It's really important to know that we have a single bud coming out of your metanephros, and as a result of that, it's going to interact with the blastema, and then you're going to have development of your mature kidneys, right? But sometimes this bud is going to bifurcate into two parts. So as it bifurcates into two parts and it's now interacting with your blastema, in the end, you're going to be having a kidney that consists of two ureters, right? And there is going to be a lot of problem associated with that. Because we discussed that the insertion of ureter within your bladder is going to be at a specific angle and a specific place. That is your trigone and at a specific angle. If the angle is disrupted or the insertion is disrupted, we're going to be having a phenomena of VUR.
Reflux.
Reflux.
Right?
Exactly.
And if
Yeah,
VUR,
increased UTIs. Yeah.
perfect. So it's going to increase the risk of UTIs. And in VUR, which portion of your kidneys are more going to be affected? Keep that in mind, really important. Reflex nephropathy.
Pelvis.
It was one of your UWorld MCQ as well.
I think it was the upper and lower.
Upper and lower pole, perfect. So the upper and lower pole basically have a complex kind of, structures, a complex kind of glomeruli, a complex kind of nephrons. And so these complex nephrons basically are or do not have any opening or valves, right? So whenever we have reflux backward, so these complex nephron areas which is more abundantly present at the upper and lower pole are going to be affected more. So in the reflex nephropathy, we are going to be seeing scarring specifically in the upper and the lower pole of your kidneys. Is that clear?
Yes.
Okay. So the next topic which we are going to discuss is posterior urethral valve. The first thing which should be in your mind is that it's basically a problem of male infants, right? Okay. Hello?
Yes.
Hello?
Yes.
Okay. So it's basically going to
Yes,
be
sir.
like, okay. So it's going to be like a male infant who's having like a posterior remnant of your posterior urethra. So as a result of that, what would happen? The urine which is draining from your kidneys, from your bladder, won't enter into your amniotic space, right? So if it isn't entering into amniotic cavity or space, so won't it lead to hydronephrosis? Or sorry, like oligohydramnios?
Yes.
And Porter's
Yes,
sequence?
it can
Yes.
cause
So we can see
oligohydramnios.
oligohydramnios and Porter's sequence. And one thing which you should just keep in mind, as the urethra is being affected in this condition, which is the common outflow for both of your kidneys. So if you are just obstructing that part, which is a common outflow for both of your kidneys, So we are going to have stasis or hydronephrosis that is going to be seen bilaterally in neonatal ultrasound, right? So whenever we have a male infant having bilateral hydronephrosis of the kidneys, the first differential which is just come on your mind is posterior urethral valves. Okay.
Okay.
Okay. Okay. And as we are increasing the pressure within the bladder, so won't it lead to VOR again?
Yes.
Yes. So we are going to see
UTIs.
VOR, right? And increased UTIs chances. Okay.
Yeah.
So that was all about our embryology. So now let's discuss our anatomy, right? So for the anatomy, you guys should know. For example, if you are doing transplantation, so the right kidney is going to be taken or the left kidney is going to be taken for transplantation.
Left,
What's the reason?
left
Left
will be
is taken.
taken
Why?
because the left
That is
kidney
longer,
is longer.
longer renal vein. Yeah.
Longer renal vein. Perfect. Then the course of ureter, right? So for the ureter, you must know the blood supply. The proximal part of the ureter, as it is close to your kidney, so it's going to be supplied by your renal artery. In the middle, you have anastomosis of a lot of arteries, right? But at the end, it's going to be supplied by two arteries. One is your vesical arteries. What's the next?
Internal iliac.
Internal iliac, right?
cycle.
So you're going to be having an MCQs. They're going to tell you that we just transplanted a kidney, right? Along with ureter, for example, right? So suddenly the proximal part of the ureter get infarcted. So what do you guys think? What's the which blood supply is basically going to have problems? So that's going to be a renal artery. Because we
Renal
know-
vessels.
Yeah.
Renal artery.
artery. Perfect, right? So let's discuss our renal physiology now. So this was all about anatomy. These were the main important features or the main important. Okay, and during gynecological procedure, water under the bridge. Remember, the ureter is more commonly going to be injured because it lies in proximity with your uterine arteries as well as your ovarian arteries, right? Okay, let me ask you another thing. Ovarian arteries are basically present within the ligament. What's the name of that ligament? Really important.
Broad ligament.
Infundibulopelvic.
Infundibulopelvic ligament, suspensory ligament. Remember?
Yeah.
Yes, yes,
Okay.
remember.
Let's keep that in mind, okay? So the next topic is going to be our physiology. So with that, we have successfully finished off our embryology and anatomy. We discuss like the entire New World MCQ, which you are going to be asked. Okay, okay. So about ureter, we are going to discuss it in a while. Okay. So the fluid compartments, we know that we have a rule which is known as 60, 40, and 20 rule. So what does the 60, 40, and 20 rule states that out of total body weight, 60% is water, 40% is present within the cells, intracellular, and 20% is present outside your cell, that is extracellular fluid volume, right? Hello?
Yes.
Okay. And okay, what's the value for the normal osmolarity? What's the, you know,
275 to 295.
295, perfect. And it is basically provided by the you know, the charges, or you can say the ions, Na, sodium, right? Sodium is the most important determining factor of your osmolarity because it's a good osmol for your extracellular fluid compartment, right? So within the cells, we have certain ions like a bag of potassium, you know, we have magnesium, we have phosphate there in order to form ATP. So within the cell, you have these kind of ions. But in extracellular fluid, you have sodium and chloride. Sodium is positive, so it would attract chloride towards itself. So this NaCl is going to be the main osmol present outside your you know, cells in the extracellular fluid compartments. Okay. So the next thing is your glomerular filtration barrier. So what is glomerular filtration barrier? As we discussed, your glomeruli basically have a barrier, right? And this barrier basically comprises of your endothelium, basement membrane. Upon the top of that, we have epithelium made up of podocytes, which are, you know, fruit-like processes. And we have a negatively charged molecules, which is known as heparin sulfate, present within the podocytes process. Remember? Hello?
Yes.
Yes.
If this negative barrier is lost, it's going to result in certain syndrome. Which syndrome? Nephrotic syndrome, right?
Nephrotic.
Nephrotic syndrome. Yes.
Nephrotic syndrome. Perfect. Okay, so we are going to discuss that in our nephrotic syndrome section today. So let's wait for our pathology part, right? Okay, then we have our renal clearance. What is clearance? As we already discussed, it's basically the ability to clear certain things or certain substances out of your blood. That's clearance, right? So in order to determine or in order to calculate clearance, what we have to do, we have to take three things, if you guys remember, right? So we have to take the concentration of that substance for which we are just you know, finding out the clearance. You have to take the concentration in the blood. You have to take the concentration of that substance within the urine, and along with that, you have to find the urine flow. For the urine flow, we have to collect 24 hours of urine divided on time. So in that way, we are going to be having the value of urine flow. And we have to put it in a formula, which is clearance equal to UV divided by P. So U stands for the concentration of urine, the concentration of substance, which is in the urine. UV, V stands for the flow rate, and P stands for the plasma concentration of those substance. If you put it in this formula, you are going to find the renal clearance, okay? So if the clearance is less than GFR, what do we assume?
It means there is net reabsorption is getting on.
Reabsorption in the peritubular capillary part. If the clearance is more than GFR, it means there is some kind of excretion. If the clearance is equal to GFR, it means nothing happens in the middle, right? So this, you are going to be having an MCQ related to this points as well. Keep that in mind, okay? Your viewer lens. Then we are going to discuss what is glomerular filtration, right? It's really easy. The amount of plasma which is filtering out through your glomeruli per time or per minute is known as your GFR. So we know in order to filter out your plasma, there are some Starling forces. We keep on discussing that again and again. That is the hydrostatic pressure is going to help the fluid move out of your glomeruli. Similarly, the osmotic fluid which is present within the glomeruli would love to attract the fluid. It won't leave the fluid to move out through your glomeruli, right? Besides that, we also discussed if the hydrostatic pressure is higher outside your glomeruli, it's going to push fluid within your glomerulus, right? And besides that, we also discussed if the osmotic pressure outside your glomeruli in the Bowman capsule is more, so it's going to increase your GFR, it's going to attract more fluid towards itself, right? So this was all about GFR. But in order to determine GFR, basically we have to find certain substance which only move out through your glomeruli, and nothing happens in the middle. And if you calculate the clearance of that substance, that would be same as GFR. As we discussed, clearance is equal to GFR when nothing happens in the middle, no reabsorption or no secretion. We already know that. So which substance can we use in this case in which the clearance is equal to GFR? What do you guys think?
Inulin.
Inulin. But the problem with inulin is that we have to inject it from outside. So what's the substance which is being made inside our body?
Creatinine.
That is creatinine, okay? But what's the problem with creatinine? I think it overestimates your GFR by a little bit value, right? So you have an MCQ of you regarding this point as well. They're going to ask you that what's the problem, okay? So it will slightly overestimate your GFR, okay? Hello?
Yes.
Okay.
Hello. Yes.
The next one is your renal blood flow autoregulation, right? So what is renal blood flow autoregulation? So the autoregulatory mechanism to help maintain your renal blood flow. As we know that during a constant period of your blood flow, what happens that the kidney basically maintains a constant, flow of blood in that range, right? So there are two mechanisms which basically keeps on autoregulation inside your kidney, right? What is that? The myogenic and tubuloglomerular mechanism, right? So what happens in myogenics, if the stretch in the renal artery is more, what your renal artery is going to do is going to constrict. So there is going to be, more pairing, or there is going to be more calcium influx, which is going to lead to contraction. And as they contract or constrict, the renal artery is going to become more thin. So in that way, if the pressure increases, still we are having a constant blood supply to your kidneys. Is that clear? So this is the first way, which is known as myogenic mechanism, okay? Hello?
Okay. Yeah.
Okay. So what else that we have tubuloglomerular mechanism. What is tubuloglomerular mechanism? If you guys remember, the NaCl delivery to macular densa is also really important. Okay.
Yes.
Yes.
Okay. So as we discussed that whenever we have less delivery of NaCl to macula densa, two things are going to happen. What your macula densa is going to do, you know that macula densa is basically a part of your distal convoluted tubule, right? Part of your distal convoluted tubule. So what would happen as a result of that? If we have less sensing of NaCl by macula densa, it's going to think of that whether we have less blood supply, right? If we have less. So what your macula densa is going to do is going to trigger the release of renin from your JG cells, right? Which is going to activate your RAS system. What else? If you have more delivery of NaCl to macula densa is simply going to think whether we have some high pressures. So what it's going to do is going to constrict your renal artery. So that's another mechanism of getting constant blood flow into your kidneys. Is that clear?
Yeah.
Oh, perfect. So the next one is effective renal plasma flow. So how do we calculate effective renal plasma flow? That's very important to keep in mind, right? In order to calculate your effective renal plasma flow, you have to use certain substance which is 100% excreted by your kidneys, 20% from your glomeruli and 80% from your peritubular capillaries, right? If we calculate the clearance of that substance, it's going to give us the effective renal plasma flow, or the plasma which is flowing into your kidneys, throughout your kidneys. So what's that substance? Which substance have similar nature? As I discussed, 20% being moving out to your glomeruli and 80% being moved out to, that is PAH, para-aminobutyric acid, right? So if we just administer PAH, we calculate the clearance of PAH is going to give us the value of effective renal plasma. That's really important. We have a lot of UL MCQ on that, okay? Is that clear? Hello?
Yes.
Okay. Then you should just keep two things in mind. The two mnemonics, by the way, PDA and ACE. Angiotensin 2 constrict your efferent arteriole, ACE. Angiotensin 2 constrict efferent arteriole. PDA, prostaglandins dilate your afferent arteriole. And why is that important? That's really important. For example, if I'm giving an individual, okay, this is going to be one of your MCQ of your, NBME 28, right? They're going to ask you, we have an individual who was having a chronic back pain, we give him some NSAID, let's suppose ibuprofen, right? What would happen to GFR?
It will decrease.
It would decreased causes different arteriolar
Because your
constriction.
NSAIDs are going to knock off your prostaglandin, you won't be having that proper dilation, it's going to constrict, and as we are having constriction of afferent arteriole, what would happen to glomeruli or GFR? GFR is
Decrease.
going to be decreased. Angiotensin 2, we have an individual, he's having diabetes, right? Why is ACE inhibitor, okay, for example, if the same individual develop hypertension, why are the ACE inhibitor better option?
They constrict the efferent arterioles and increase the GFR.
Yes, because we are removing that extra constriction provided by angiotensin 2, right? That extra constriction due to angiotensin 2, and in diabetes we discuss in detail. Efferent arteriole is the first arteriole which is going to be affected by non-enzymatic glycosylation, right? We discuss each and everything. It's a kind of revision session for you. I think that things are making a lot of sense now, right? Hello?
Yes.
Oh, that's perfect. So let's discuss some changes and the GFR changes and filtration fraction. So it's going to be a task for you guys. So let me ask from you guys. Let me just select anyone. Okay, Dr. Jamil. Jamil?
Yes, sir.
If the afferent arteriole is constricting, what do you think what will happen to GFR?
It will decrease.
GFR is going to decrease. What will happen to renal plasma flow?
Renal plasma flow also decrease.
What will happen to filtration fraction?
It will decrease also.
Decrease or constant if both of them are
Stay
decreasing?
normal.
Sorry,
become
sorry.
normal.
If they both decrease, then the equal, not unchanged. Sorry.
It's going to be constant
Because GFR
filtration
over
fraction
renal
is-
plasma flow. Yes.
Perfect. Okay, so another question for you, Dr. Jamil. If
Yes.
you are constricting the efferent arteriole, what would happen to GFR and why?
And GFR, it will increase because there is, if we constrict, that means that the backup pressure will be increased,
Yes,
and
we
it
have
will
backup
increase
pressure.
pressure, hydrostatic pressure in the Bowman capsule. It will increase the filtration rate.
Yes, it's going to increase the GFR. So for the renal plasma flow, what will happen to the renal plasma flow if you are constricting the efferent arteriole?
It will decrease renal plasma
It
flow.
will decrease as well. If GFR is increasing and renal plasma flow is decreasing, so what will
Yes,
happen?
it will increase the filtration fraction.
Increase filtration fraction. Okay, if we are increasing the plasma protein concentration, if I'm dumping off a lot of plasma protein, what will happen to GFR in that case?
GFR will decrease because due to increase of oncotic pressure.
Oncotic pressure, so what your osmoles are going to do, they won't allow the fluid to move out because they are a
Yes.
good suction molecules. You can simply imagine that like that, okay? And what would happen to the renal plasma flow? No effect.
No
Because
effect.
giving off a lot of plasma protein won't have any effect on the renal plasma flow. So what would happen to filtration fraction then?
Filtration fraction will decrease.
Decrease. Perfect. Okay, if I'm constricting the ureter, one of your UL MCQ, what will happen to GFR and why?
If we decrease the ureter, then it will increase the hydrostatic pressure in the Bowman capsule. It will decrease the GFR, and it will decrease also the filtration fraction due to
Yes,
opposite forces in the Bowman capsules.
perfect. So can it lead to post-renal azotemia as we discussed?
Sorry, sir.
Post-renal azotemia, remember?
Yes,
Yeah.
yes.
What is
Yes,
your
it's
Yeah, it will
cause.
cause the post-renal cause.
Perfect. So again, one of your MCQ of your MDME 28, right? An individual, he is running a marathon just like you guys right now. So he's going to be dehydrated more, right? So what would happen to GFR?
GFR will be decreased.
Decrease.
Okay, so the GFR is going to be decreased. What will happen to renal plasma flow?
It will also decrease.
It will also, it's grossly decrease, yes.
Decrease more. So what will happen to
Yes,
filtration
grossly
fraction?
decrease, yes. Filter fraction will increase.
Increase. That's really important to know that the
Yes.
filtration fraction is going to increase. Okay, perfect. So let's discuss our next topic, that is basically, yes, please.
Sir, like when we constrict the efferent arteriole, so why does the renal plasma flow decrease as the backup pressure is already increasing?
Okay. What's the, who said that the renal plasma flow is going to decrease?
Like when we constrict the efferent arteriole, the renal plasma flow decreases.
Yes.
So like why does it happen? I'm not understanding.
Okay, this is your afferent arteriole, glomeruli, and efferent arteriole, right? Is it clear?
Yes, sir.
What is your renal plasma flow? The plasma which is flowing through entire kidneys, right? Coming to peritubular capillaries and everywhere, right?
Yes, sir.
If I'm constricting this part, the GFR increases, right? Because the backup of blood. But the plasma which is coming here decreases.
Yes.
So won't I say that the renal plasma flow is decreasing?
Okay. So
Yes,
like
it will
rest
decrease.
areas.
It will
Yes.
decrease.
Yes.
Is that clear now?
Yes, sir. It's clear. Yes.
Right?
Yeah.
Because the renal plasma flow is not that which is only present in here. It's also the part of the plasma which is moving through your entire kidneys,
Yes.
through your peritubular capillaries and everywhere, right?
Yes. Sir.
Okay, so that's the main theme, okay?
Oh,
So
thank
let's discuss our next topic, that is glucose clearance, right? Okay, so just give me a second. Someone is asking about keyword question IDs. Please tell them that our session haven't been finished. After the session, we are going to share assessment, not QIDs, right? Okay. So glucose clearance. So what is glucose clearance? As we already discussed that there are certain transporters within the proximal convoluted tubule. If you guys remember, in the management of diabetes, I discussed certain drugs as well, right? Which are going to block off those transporters. What are the name of those drugs?
Yes.
Yeah, frozen
SGLT.
drugs.
Frozen drugs.
Mhm.
What are the name of the transporters if the frozen are going to inhibit?
Glu2,
you. SGLT2.
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 Okay, SGLT2. So basically, this transporter helps you, put the glucose back into your blood, because glucose is important for your body, right? You have to. We normally do not, spill it in the urine, right? Till a certain level. If all of these transporters are saturated, after that, if you are administering more glucose, then that amount of glucose is going to move out in the urine, right? So what's some threshold for that value? Yes.
200.
200.
Less than 200.
200 which
Threshold is
become less needed,
200.
right?
And
Yes.
at 375, the transporter becomes saturated.
At 375. Perfect.
Mm.
So that's the main idea, right? Then we have a phenomena of splay, one of your UL MCQ. So you guys, I just spent a lot of time on splay, if you guys remember. So I'm expecting from you guys to tell me what is splay phenomena and what does a splay indicates. I won't repeat it again.
It means that all the transporters are not saturated at the same time. They are saturated at different timings. So that's why it's shaped like a splaying. So and it's because of the heterogeneity of all the transporters.
Perfect. It means that all of the transporters do not get saturated at a single value. They get saturated at different values of your glucose threshold. So that's why we have that slurred upstroke of the graph. That's basically indicating splay. So splay basically indicates the heterogeneity of your transported towards different value of your threshold, right? That's the main idea. Okay. So let's discuss our nephron transport physiology, right? So there are a lot of channels which we are going to memorize, which we are going to discuss, and we have almost, we are almost going to end this physiology in a half an hour, okay? Then we are going to start our pathology section. So in the proximal convoluted tubule, Dr. Mariam is going to be telling us the entire transporters, its functions and everything, different drugs acting there, different pathology of proximal convoluted tubule. Yes.
So at the level of the proximal convoluted tubules, first of all, there will be the absorption of the glucose, amino acids, bicarb, and the lot of the all these things are getting reabsorbed. So the hormones which are getting affected here, the first is the parathyroid hormone and the angiotensin 2. The parathyroid hormone acts here as a trashing hormone, and it trashes the phosphate at this level. And the angiotensin 2 act at the sodium hydrogen pump, ATPase pump, and it causes the secretion of the hydrogen ions and the reabsorption of the sodium ions. And the third thing is also there is a sodium glucose co-transporter, which we have discussed previously. So that transporter is also present here, and the GLUT2 transporters, the name of those, and the fluosin drugs act over here. So they cause the inhibition of the sodium and the glucose transportation.
Okay.
And there is also another thing, the one of the diuretic, the acetazolamide drug that acts over here at this level to inhibit the carbonic anhydrase enzyme and decrease the formation of the carbonic acid, and then the less bicarb will be formed, and the less bicarb will be excreted in the urine.
Okay.
So
Perfect.
this all will be done here, and
Okay.
yes.
Okay, so as Dr. Mariam mentioned that in proximal convoluted tubule, we are going to be having reabsorption of a lot of things. For example, 67% of reabsorption is going to occur at proximal convoluted tubule. It's a metabolically, I can say, the most active part of your nephron. So during ischemia, it's the first portion to be get, ischemic, right? Hello? Similarly,
Yes.
your parathyroid hormone also is going to act on proximal convoluted tubule. It's going to trash your phosphate. But there is another thing which you didn't mention. There is an activity of enzyme 1-alpha hydroxylase, right? In your proximal
Yes.
convoluted tubule. It's going to
Yes.
increase conversion of your active
Vitamin D.
right?
Yes.
Which is going to lead to reabsorption of your calcium.
Calcium
Similarly,
and phosphate from
angiotensin
the intestine.
Perfect.
Yeah.
From your intestines. Perfect. And another thing is your angiotensin 2. So what your angiotensin 2 is going to do, it's going to stimulate, Na and H plus pumps. That is going to increase Na reabsorption in H2. Similarly, the bicarbonates are also going to get reabsorbed in the proximal convoluted tubule. So we have a pathology which, disrupt all of your proximal convoluted tubule. What's the name of that pathology?
Fanconi syndrome.
Fanconi syndrome, for example, right? Then you have your thin descending loop of Henle. So Dr. Abdul Rauf is going to be telling us about thin descending loop of Henle.
Yes, sir. So in the descending limb of the loop of Henle, so the water will be reabsorbed
Okay.
because it's like not absorbing the sodium, so it will absorb the water, and the concentration of the urine will be increased here because it's like the concentrating segment of the nephron.
Okay, perfect. So it's basically impermeable to water, right? Perfect. And what about thick ascending loop of Henle? You already know the function, the channels. Yesterday we discussed in detail in our pharmacology section as well, I guess, right? So there's going to be a channel NaK plus and a Cl negative. It's going to be lead to reabsorption of these ions, and along with that, paracellular reabsorption of calcium as well. Remember? Hello?
Yes, sir.
Right?
Yes.
And which drugs are going to block these channels, and which inherited condition basically you lead to, non-functional channels here? Loop diuretic.
Furosemide is a drug, Lasix. It will inhibit this ascending part. And Bartter syndrome.
Bartter syndrome, perfect, right? Bartter and loop. Then we have our distal convoluted tubule. It only have like Na and Cl channels. And secondly, you should just keep in mind that so PTH is also going to act here in order to reabsorb your calcium as well, as we discussed. So thiazide diuretics are going to block off these channels, which is a diuretic. We discussed everything in detail. So what would happen in PTH? Okay, in the loop diuretic administration would be seeing hypocalcemia or in thiazide diuretics?
In
In loop.
The loop
In
would
loop
cause
diuretic.
the hypocalcemia because
loop.
they lose the calcium.
Perfect. Then we have our collecting ducts. So in the collecting ducts, aldosterone is first of all going to act, and ADH are going to act. We already know that, right? So ADH is going to install aquaporin channels, as we discussed in detail. Along with that, your V2 channel, and attracting water from the urine, right? And besides that, we have our aldosterone. So what's the function of aldosterone?
To conserve sodium
Reabsorb.
inside the body and to secrete potassium.
Perfect. So it's going to reabsorb sodium. It's going to excrete your potassium and H plus.
Acid.
That's
Hydrogen.
yes. That's the only thing which you should just keep in mind. So now let's move towards our syndromes: Fanconi, Bartter, Zitterman, Liddle syndrome, and SIADH or SAN. Okay. So what is Fanconi syndrome? You guys are going to be telling me that. What is Fanconi syndrome? Hello.
Like there will be defect in the proximal convoluted tubule, like all the things that were being reabsorbed here, now they will be excreted. Their reabsorption will not be taking place, like the
Okay, perfect. So reabsorption of what would not happen? Reabsorption of your bicarbs,
bicarbs and sodium.
sodium, potassium, what else?
Phosphate.
Phosphate as well. Amino acid, glucose. Because everything was getting reabsorbed there, right? So it won't happen. If it do not happen, what would happen if you're losing the bicarbs? So won't it lead to acidosis?
Yes, mitochondria.
Yes, we will have acidosis.
Won't it lead to hypophosphatemia?
Yes.
Yes.
How would it lead to
Hypokalemia.
hypokalemia?
Because
Yes,
the potassium
hypokalemia as well.
First of all, potassium is lost. And another thing which you should just keep in mind, the RAS system is also going to be activated, right? Because if you're losing a lot of ions, if you're losing a lot of things, so what happens? It's going to activate your RAS system, leading to hypokalemia. Okay, so the hereditary defect like Wilson disease, we are going to discuss the entire diseases like in our next module. So it's not better. It's not better to do it here. Okay, so what is your question? Won't it lead to? Okay, so someone asked a question. Yes. Okay. So if we do not have reabsorption of proper, potassium, so your phosphate, so it would lead to rickets, right? Because your bone is basically made up of calcium as well as phosphorus, right? Okay, so the hypophosphatemia here is going to lead to growth retardation, rickets in children, and osteopenia in adults. Okay. The next one is Bartter syndrome. So you already just told me Bartter syndrome. We have, reabsorption defect in.
Sodium, potassium,
Okay, that's hypophosphatemia, not hyperphosphatemia, right? Okay. So Bartter syndrome. So for the Bartter syndrome, it's going to be a reabsorption defect in these channels. If we have reabsorption defect in these channels, it's same as we are just giving an individual loop diuretics, right? So if we are giving loop diuretics, the RAS system is going to be activated, right? If the RAS system is activated, it would just push off all of the acids outward because your aldosterone push your H plus, right? Leading to metabolic alkalosis. It's going to lead to hypokalemia. And if you're blocking of these channels, we won't be having proper reabsorption of your calcium as well. So hypercalciuria or hypocalcemia, right? Hello?
Yes.
Yes.
Then we have our Jitterman syndrome. It's same as that. We are just giving an individual a thiazide diuretic. So it's basically a genetic defect of the channels present within your distal convoluted tubule, that is NaCl. Okay. So if we have problem with that, what would we see? Again, your RAS system is going to be activated, metabolic alkalosis, hypomagnesemia, hypokalemia, and hypocalciuria. Why? Because still the phosphate, the PTH is acting here, reabsorbing a lot of calcium, right? So that's why we won't see hypercalciuria. We will see hypocalciuria because we are reabsorbing the calcium still. Then you have our Liddle syndrome. What happens in Liddle syndrome? Now it is a gain of function of certain channels, right? That is your Na, right? Your Na channels. And it's similar as that of hyperaldosteronism. Are you getting my point? If you have hyperaldosteronism, won't we see metabolic alkalosis again? Yes.
Yeah.
Won't we see
Yes.
hypokalemia? Won't we see hypertension?
Yes.
Yes. Okay. So these are the things which you are going to see here, right?
Mm.
Then it's syndrome of inappropriate metallocorticoid excess. So what is, okay, this was the topic, if you guys remember, we discussed in detail in our endocrinology, right? The different, different, do you guys remember 21 alpha, 11 alpha and everything,
Mhm.
right?
Yeah.
Mineralocorticoid,
Yes.
which enzymes are required for, right? So so let's just skip this topic for now because we have just spent a lot of, okay, anyone who can just, have some discussion on this topic.
So like basically there will be deficiency of the one enzyme, the 11 beta HCD.
Okay.
HSD, sorry. So because of that, the cortisol will not be converted to its inactive components like the cortisol. So the body will experience more cortisol in it. So the cortisol will start behaving like an aldosterone. So it will look like that there is more aldosterone in the body, but actually in reality there will not be more aldosterone. Either it will be normal or it will be reduced. But the increased level of the cortisol would be acting as like the aldosterone. So that's why again we would have the metabolic alkalosis and the hypokalemia. But in reality, the levels of the aldosterone would not be increased.
Perfect. Perfect. Really good. Okay, that was explained really great. Okay. Okay. So the next topic is, it's there is a chart. You can just view it by your own. We already discussed everything here, right? Okay. So the relative concentration along the proximal tubule. It's really important. You have a UR density on that as well. So just keep in mind one thing. In the graph, okay, have you opened your first aid book page? That is your, okay, what's the page number 6 or 5? You guys
Yeah.
can see a graph. So the same graph is going to be mentioned in your UR question. They are going to ask you different, graphs indicates which substances. So the graph which are moving upward above the baseline, right? Above the baseline. It basically means, let me just clarify it. Let me just make it really simple. You don't have to, read the first aid here, right? You should just keep one thing in mind. Basically, as we move along the tubules, the concentration of certain substances are going to increase. And what's the main goal behind that? Whatever we want to excrete out of our body, whatever we want to excrete out of our body in a form of urine, so moving along the concentration or moving along the length of tubules, in the end, the concentration of those substances is going to be increased, right? For example, we discussed pH. You have to excrete pH 100%, right? So as we are moving along the length of the tubule, in the end, the pH concentration is going to be, increasing, right? Like some of it would be coming from your glomeruli 20%, and the 80% as we just move downward, the peritubular capillaries are going to dump off the remaining 80%. In the end, you are going to be having 100% excretion of that pH, right? Hello? Hello?
Yes, sir.
Okay, so you guys can see that the graph here is on the top. The next one is creatinine, right? So we discussed creatinine, not clear. What's not clear? Let me just tell you, okay? This is your tubule, right? Loop of Henle, your distal cannula tubule, your collecting mass. We discussed that the PAH is excreted out 100%, right? Okay. We discussed 20% of it comes from glomeruli, and the remaining is, excreted out from your peritubular capillaries, right? So as I'm moving along the length, here it's only 20%. Here still it's 20%. But now your peritubular capillary is going to dump off the extra 80% of your PAH. So moving along the length, the PAH concentration increases. So whatever I want to dump off in urine, whatever substance which I want to, clear my body off, moving along the length, the concentration of that substance is going to increase. That's simple. Is it clear now?
Yes. Yes.
Yes, sir.
So we excrete out pH 100%, right? So as I'm moving along the length of the tubule, so what happens? pH is going to be 100% excreted. Okay. Now how to relate it to the graph? pH come on top because you have 100% excretion of pH. So on the top, you can see the graph is at the top, right? As we are moving along the length of proximal convoluted tubule, the concentration rises on the top because 100% excretion of pH occurs. While on the other hand, for the creatinine and alanine we discussed, it only moves out through your glomeruli, but some of it is excreted out through your peritubular capillaries. Remember in case of creatinine, right?
Yes.
Right. So it's
Yes.
going to be on the second number, right? Not 100% get excreted, right? It's going to be on the second number. The third one is your urea. What is urine? Urine basically is having urea. Okay, so the urea comes on third, then your chloride come on fourth, and on the baseline you have your Na, right? And as we are just moving downward, whatever we want to reabsorb are going to be present down below the baseline graph, right? So we want HCO3, right? Yes, you have to memorize the graph, but you should know the concept, what's happening here, right?
Yes.
Okay. So we want to reabsorb the HCO3, so it's going to come here. But we want to reabsorb the amino acid and glucose more than HCO3. We want them more. So it's going to be like, as moving along the length of the tubules, in the end, it's going to be very less. Okay, that's the main idea. Is it clear?
Yes.
Okay. So then we have our RAS system. I think I have discussed RAS system about about 20 times, right? So I'm expecting from someone who can just repeat this RAS system concept for me. Anyone?
So like when the blood pressure would be like there's some trigger for the RAS system to get activated. So when the blood pressure is less blood is getting into the body, so the afferent arterioles will sense it. The renal baroreceptors are present there. Or when there is decreased sodium chloride delivery, it would be sensed by the macula densa. Or either when there is increased sympathetic tone in the juxtaglomerular apparatus, or their sympathetic system get activated. So these three trigger will simply lead to the release of renin. And renin would simply convert the angiotensinogen, which is released from the liver, into the angiotensin 1. And that's angiotensin 1 is then basically converted into the angiotensin 2 by the angiotensin converting enzyme, which comes from the lungs itself. And then the angiotensin 2 has all the other effects that is causing on the different areas. Like it would act on the efferent arteriole to constrict them. So when they will be constricted, so the GFR would be increased and the filtration fraction would also be increased. And similarly, the angiotensin 2 also act on the vessels to cause vasoconstriction to increase the blood pressure. And it also act on the proximal convoluted tubule cell to act on the sodium and hydrogen pump. So because of that, reabsorption of the sodium and bicarbonate ion and other ions will take place. And the other two actions are basically combined effects of like ADH and aldosterone, because the aldosterone when will be released, it will also act on the principal cell to basically cause the sodium reabsorption and potassium secretion. And on the other alpha intercalated cell, it would cause the hydrogen secretion. And the ADH would also act on the principal cell to basically insert those V2 receptors, I think, like the channels aquaporin, to cause increased water reabsorption. So this will all be the combined effects of the angiotensin 2 that are coming from the RAS system as a whole.
Okay, that's perfect. Okay. So as Dr. Abdurrauf explained it really well. So I think it's there, right? So let's just move to our next topic. Okay, from where do erythropoietin comes? That's really important. One of your dual MCQ as well.
The peritubular capillaries.
Interstitial cells in the peritubular capillary bed.
Okay, interstitial cells. Okay, perfect. Okay, how does the activated vitamin D? How do we get activated vitamin D? We have discussed that a lot of time as well. So who can just tell us the entire pathway? First of all, sunlight is going to fall on your skin, right? What would happen after that?
So the vitamin D goes to the liver to become the 25-OH vitamin D.
Okay.
And then it goes to the kidney in the proximal convoluted tubule cells, where the 1-alpha hydroxylase converts the 25-OH vitamin D to 1,2,5-OH vitamin D.
Okay. Okay.
And
what would happen as a result of that? This activated vitamin D is going to go into your gut. It's going to lead to the absorption of your calcium as well as your phosphate. Right?
Yes.
Then you have your prostaglandins, right? We discussed what's the function of prostaglandins. They PDA dilates or different giving NSAID is going to lead to constriction. Simple. Dopamine. Some of the dopamine is made by your proximal convoluted tubule as well. It's really important. What's the nature of dopamine at low doses and high doses? Really important one of your world MCQ. Yes.
At low doses, it affects like a dilator, and at high doses, it affects like a vasoconstrictor.
That's all. Perfect. So at low doses, dopamine is going to be a vasodilator, right? And at high doses, dopamine is going to be vasoconstrictor. Anyone do anyone have any mnemonic to remember it? Hello?
No, sir.
Okay, just make one. It's going to be really important concept for you guys, okay? Okay. So the next topic which we are going to discuss is electrolyte imbalances, right? Or okay, okay, let's discuss acidosis and alkalosis, right? And the acid-base physiology, right? So it's going to be the last topic for today. And you have renal tubular acidosis, so you can just read it by your own, okay? It's your task, your home. Since we have to complete a lot of pathology as well, so that's why only going to discuss the high yield, right? Okay. So let's discuss. Okay, first of all, let's have a little bit break, right? 10 minutes of break. What do you guys think? Then we are going to start the acid base since we are going to spend a little bit time on acid base. We already have did that. It's going to be a kind of revision for you guys, and then we are going to start our pathology, right? For pathology, we are going to use pathoma, so everyone should be having pathoma in front of them, right? Okay, thank you so much. See you after 10 minutes. Hello? 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 Can you guys hear me? Hello?
Yes, doctor.
Okay, so let's discuss our next topic, that is acid-base physiology, right? So for the acid, okay, just give me 5 minutes, okay, please. Let's just continue for 5 minutes. Very important. Hello? Okay, so let's discuss our topic, that is acid-base physiology. Can everyone hear me? Hello?
Yes.
Okay, so as you
Yes.
guys know that we discuss acid-base physiology in quite detail. So everyone should just keep open their first chat page 610, right? So looking towards this chart, everything is going to be really easy for you guys. We discussed that what is acidosis and what is alkalosis, right? We discussed whenever the acid content within our body increases within our blood or our body, that's going to be acidemia, or it can lead to acidosis as well. Similarly, if the level of the bases or the alkalis, right, and the main alkali present in your body is HCO2, whenever it increases, so basically we have a balance between acid and bases, right? So whenever we are disrupting the balances on either side, or the acids, if we are increasing the acids, we are going to be having acidosis. If we are increasing the alkalis, again, we are going to be having acidosis. Similarly, if we are decreasing the alkalis, so obviously the balance is going to shift towards having more H pluses, right? Or having more acids. So again, it would be acidosis, right? So in order to assess such kind of questions of acid base, first of all, what you guys have to do, you guys should know the normal value of pH. So who is going to be telling me the normal value of your pH, the normal pH?
7.35 to 7.45.
Perfect. It's 7.35 to 7.45, right? So whenever the pH is less than 7.35, it means we have acidosis, right? Because less pH means more H pluses. We have a log of H pluses, right? An equation, Hazelberg equation, if you guys remember, right, from your chemistry, that is pH is equal to log of H plus divided by HCO3, right? So basically, we are going to be having, whenever the pH is less, it's going to be acidosis. Whenever the pH is higher than 7.45, it's going to be alkalemia or alkalosis, right? If the pH is less than 7.35, now the question should arise that we have acidosis. So, but acidosis can be due to any problems within your lungs or problems within your metabolic activities, right? That is, whenever your lung is hypoventilating, right, it's going to lead to retention of more CO2. And CO2 is going to give you acids in your body. How? it's going to react with your water by using carbonic anhydrase, giving you H pluses, right? More H pluses, right? So anything which is lead to hypoventilation is going to cause acidosis due to retention of carbon dioxide. But since it's a problem related to your lungs, so let's call this kind of acidosis as respiratory acidosis, okay? Hello?
Yes.
So what leads to hypoventilation? There are a lot of causes of hypoventilation. For example, opioids use. For example, if you have, nephropathy of the, let's suppose, phrenic nerve, the diaphragm isn't functioning well. If you have edema can also lead to interstitial lung diseases. Everything can lead to hypoventilation. We are going to discuss that.
Opioids.
Right? Opioids use, yes. Sedatives use. Okay, so it's going to be but we also know that whenever there is problem with your lungs, so the kidneys are, their best friends. They would try to compensate. If you have acidosis, what kidneys are going to do? They are going to then dump off a lot of H pluses, or they can retain more HCO3 in order to neutralize the balance, right? So that's a concept of compensation, right? The next is metabolic acidosis. What is metabolic acidosis? Any problem with your metabolic problems? As we discussed, when HCO3 is less in the balance, again, you are going to be having acidosis, right? Because you have a balance between acids and bases, right? If you are losing bases, it means you are retaining more acids, right? Again, it's going to be acidosis. But this time the problem is related to any metabolic problems, right? So it's going to be called as metabolic acidosis. But whenever you have metabolic acidosis, so things get a little bit complicated there. It's not simple as the other cases. We have to find something which is known as anion gap, right? And what's the formula for anion gap? And what's the concept we're going to be telling you that?
The sodium minus the chloride and the bicarbonate ion. Basically, the positive ion minus the negative one.
The positive ion minus the negative ions. Because sometimes what happens, we can have accumulation of an extra anions, some extra anions, which can lead to acidity or acidosis, right? And what are them? They are your, uremia, if you guys remember, is lactate. In CKD, it's going to be renal failure uremia, right? Aspirin use, a lot of MCQs you guys are going to see from there. So if the ratio or if the difference is 12 or less than 12, that's normal, because normally we can have some extra anions, but that's normal. But if the anion gap is more than 12, it means some extra things are coming and which are just causing this metabolic acidosis, right? And that's clearly mentioned in the first slide. You guys can just see that, okay? Okay, so still, if the ratio is less than 12, we can also have acidosis in that cases as well. But now the things are going to be different. And the mnemonic for that is spironolactone, Addison disease, renal tubular acidosis. Each and everything can lead to acidosis. But it's now not due to some extra anions, right? So this formula is going to tell you whether we have anion gap metabolic acidosis, if the difference is more than 12, or if you have normal anion gap metabolic acidosis. Is it clear?
Yes.
Yes, sir.
Okay, perfect. On the other hand, let's discuss alkalosis or alkalemia. Again, if the pH is more than 7.45, it means we have alkalemia or alkalosis. Now, again, there can be some problems with the respiratory system, or there can be some metabolic problems, right? So, for example, if an individual is hyperventilating, it means he is blowing off more carbon dioxide, he is blowing off more acids. Blowing off more acids mean the balance is going to shift towards having more bases, right? Which is going to lead to alkalosis. So in anxiety attacks, in pulmonary embolism, everything is going to lead to hypertension, which is going to give you respiratory alkalosis. Is it clear? While in case of metabolic, alkalosis is going to be a problem, anything due to metabolic problem. For example, if an individual is vomiting more, he's losing more acids in his vomit, right? HCl. Again, it can lead to metabolic alkalosis. So that's the general concept which you have to keep in mind. And all of the causes and all of the things are already mentioned in the first slide. You only have to memorize it and make sense out of that, okay? Hello?
Yes, sir.
Is it clear? Okay, so
Yes.
now there's a topic of renal tubular acidosis. As I already mentioned, it's going to be your homework. So now let's begin our section of pathology, right? Our pathology section. So I want everyone to keep open their pathoma in front of them, because we are going to discuss this topic from pathoma, okay? Okay, so I'm giving you 3 minutes. Those who do not have Dear Patoma, kindly grab your book. Just open it, okay? Okay, have you guys opened your book? Hello?
Yes, sir.
Okay, that's great. So let's start our first topic. Okay, we already have discussed how to shape kidney, renal agenesis, polycystic kidney diseases. So let's just come directly to acute renal failure. So we discussed what is acute renal failure in detail, if you guys remember, right? Whenever your kidneys aren't going to function well within, it's an acute condition, so it would occur within days. So what's the main hallmark? What's the function of the kidneys? The kidneys basically are going to excrete out your creatinine, right? It's going to excrete out your nitrogenous bases, right? So within days, if you keep on accumulating these creatinine and BUN within the blood, it means the kidneys aren't functioning, right? And the kidneys won't produce enough urine as well. So that's going to be oliguria. So whenever you see these three things within days, it's going to be called as acute renal failure, right? There are a lot of causes of acute renal failure. That is any problem which arises before your kidneys, in the kidneys, and after the kidneys, right? So any problems which arises before the kidney, like before the kidney, we have renal arteries and we have your entire circulatory system, right? So that's going to be called as post-renal azotemia. How? For example, if you have an individual, he's having an excessive hemorrhage, right? If he's having an excessive hemorrhage, he's going to be having less effective circulatory volume, less blood is going to enter into his kidney, less blood is going to enter his kidney, his GFR is going to be less. If GFR is less, we won't be clearing out the creatinine and BUN. It's going to accumulate within your blood. So that's basically azotemia, right? Within days, even within hours, if you have this condition, if you have a big hemorrhage, right, you're losing a lot of blood. It's going to lead to, okay, so the pathology is basically before the kidney, so let's call it as post-renal azotemia. We are seeing azotemia, that is a decreased GFR, increased nitrogenous bases, BUN. But an interesting thing which you have to just keep in mind, a lot of MCQs from here, is that you have to be concerned about the health of tubules, right? What do you mean by the health of tubules? What's the function of tubules? Normally we discuss it's going to reabsorb a lot of things, right? It's going to reabsorb a lot of things. For example, your ions, it's going to reabsorb, your ions along with that water. So as we are having pre-renal azotemia, that is whenever we are having loss of that extra, the blood. So what happened that it's a pre-renal azotemia. As a result of that, your RAS system is going to be activated, right? And whenever the RAS system is activated, it's going to lead to reabsorption of your sodium, and the sodium is going to be followed by water. And the water is going to be followed by urea, as we discussed, right? Okay. So since in pre-renal azotemia, the tubular health is good. The tubular health is good. So what will happen to the ratio of BUN to creatinine? It's going to be more than 50 because the tubular health is good. It can reabsorb water. It can reabsorb BUN. So the ratio is going to be more than 15. More than 15 ratio means that the tubular health is good. Okay. Besides that, the fractional excretion of sodium. What is fractional excretion? Normally we need sodium. We need to reabsorb sodium, right? So if you see the fractional excretion of sodium, it's going to be less than 1%. It means the tubules are healthy. They can still reabsorb your sodium, right? What's going to happen to urine osmolarity? It's going to be more than 500. What do we mean by more than 500? That your tubules are healthy. They can reabsorb water, right? So all of these things indicates healthy tubules. If the ratio is reversed, that is less than 15, it means the tubules are not healthy. If the fractional excretion is greater than 2%, it means still the tubules are unhealthy, which we are going to see the condition in our next sections. Okay, is that clear?
Yes.
Hello? Okay, so the next topic is our post-renal azotemia. So what is post-renal azotemia? Any problem which arises after your kidneys. For example, your ureter get constricted. The ureter get constricted, we already discussed. The pressure in the Bowman capsule increases, it's going to decrease your GFR. And as the GFR decreases, excretion of your creatinine decreases, excretion of your BUN decreases. So still within the days, you are going to see azotemia, which ended in this case, the reason is after the kidneys, that is, the ureter comes after the kidneys, ureter contraction or constriction. So it's going to be a post-renal azotemia, right? But one thing to keep in mind, initially, the tubular health is going to be normal. So how do we indicate the tubular health? BUN to creatinine is going to be more than 15. The fractional excretion of Na is going to be less than 1%. Besides that, the urine osmolality is going to be greater than 500. But a time would come that the tubular health would decline as the tubular, if there is a long-standing obstruction. So the tubular health is going to decline, and as the tubular health declines, what happens? Everything reverses. That is, now the ratio is going to be less than 15. Fractional excretion is going to be more than 2%, and you are going to be having a concentrated inability to concentrate your urine or reabsorb more water. That's the main thing to keep in mind. Okay. So the next one is acute tubular necrosis. So who is going to be discussing this acute tubular necrosis? Hello, anyone?
Like it is the kind of condition like mostly seen in the hospitalized patients who are in the hospital. And
Okay.
this disease would basically, it's comprising of the mid part, it is describe the intrinsic renal failure. And in this disease, we will see basically three phases. The first would be the initiating phase, in which the patient will experience a mild degree of like oliguria. The urine volume would be less, and most of the fatalities occur during this phase. And then
Okay.
it would basically go toward the maintenance phase, where he will still be oligouric, but we can see like hyperkalemia or metabolic acidosis in it. Like it can go on about for like 2 to 3 weeks. And then we would come toward the recovery phase, in which his urine output would increase, and there will be like now hypokalemia, and there can all the his blood urea nitrogen level would fall, and the creatinine would also fall. So there can be like two causes that can precipitate to it. Like either there can be some kind of ischemia, so the blood reaching the kidney is less, the renal blood flow is decreased, and
Mhm.
when it is decreased, so of course there will also be some necrosis of the cells of the tubules, which will flow into the tubules, and they will also cause some degree of obstruction. Or
Okay.
we can also experience it by drugs, which will be a nephrotoxic injury. Certain drugs like aminoglycoside or the ethylene glycol, these kind of drugs, or some kind of radio contrast dye or anything, that can also basically cause this nephrotoxic injury. And the most important thing is that mostly it will involve injury to the proximal tubules of the
Yes.
nephron.
Perfect. Perfect. So this was all about our acute tubular injury. So I have a request for you guys that I'm just feeling a little bit there now. So we can just continue the session tomorrow, okay? After Dr. Mo's session. And what I'm going to do now is that you guys are going to be having an assessment session, right? Since you guys also took a long sessions, 2 hours with Dr. Mo and 2 to 3 hours with me, with Dr. Hassan and all. So I think it would be quite hard for you guys as well, and for me as well. Okay. So I'll be sharing the assessment within 1 hour, right? Once I just make the assessment, I'll be sharing the link. So do not forget to give your assessment. Okay. That was all. We are only left with nephritic and nephrotic syndrome that we already discussed. You guys already have idea of that. 2 days back, we discussed everything, right? It's a kind of reunion session for you. So I'm expecting you guys to participate there, and I'll also be sharing the task for your respiratory section, as well as Dr. Moss covered the physiology. I'll be going through the physiology again with you guys, okay? But it will just take a little bit time. And one thing which I want to mention for Dr. Hasnain, right? So Dr. Hasnain is soon going to join us in this marathon discussing the dual session. Okay, so that's all. Thank you so much, guys, for listening towards us and following the schedules. And thank you so much. Okay, see you tomorrow.
Thank you.
Oh my God, we forgot. This that's our rotten shirt and we. I think it's treated 4x4, we can stand it down on there, longer. So this problem is something that we can now address, fix, and it really won't cost